Okay, we're on chapter 13. We're going to start learning about vital signs and how to monitor our patients. That's on page 306. So, vital signs are very important, and gathering those vital signs gives us a good indication of the patient's status throughout the time we take care of them. The primary assessment gives us the knowledge about life-threatening conditions that need to be treated right away. But vital signs don't actually get taken until the secondary survey, which will be the chapter 14. Gathering vital signs. The importance of vital signs is that it tells us what's going on inside of the body. It also gives us important conditions, or what we call trends. We always trend our patients' vital signs. Every patient should have at least two sets of vital signs throughout the time we take care of them. If they're critical patients, you take the vital signs every 5 minutes. If they're fairly stable, it's every 15 minutes. So vital signs need to be taken on every EMS patient. It tells us the severity of their condition, and it also tells us if there's any changes throughout the time that we take care of them. Vital signs. What are vital signs? Well, the common vital signs that we deal with and take care of in EMS are pulses, respirations. We look at the skin, color, temperature, and condition. And on kids, we do what's called a capillary refill check. It gives us an idea of the circulatory status of the child. We look at pupils, and we take blood pressure. Now, our baseline vital signs is the very first set of vital signs that we obtain. And then we have repeat vital signs after that gives us even more information and begins to establish trends. Pulses, we can check. Generally in the alert patient, we check a radial pulse, which is by the wrist, and a carotid pulse for an unconscious patient. But the pulse is the pressure of the heart beating as it goes through an artery, and wherever an artery crosses over a bone, you can compress that site and feel a pulse. So you want to take your fingertip and put it over the artery and press it just a little bit, and you'll feel that pulsating as the heart beats and the blood pushes in waves through the artery. So how do you know how fast a pulse is? Well, you got to count it for 30 seconds and then multiply it by 2. You also, when you're taking a pulse, feel the quality of the pulse. You want to know how strong it is, how regular it is. The pulse rate is the number of beats per minute. On a normal adult that's at rest, it's between 60 and 100 beats per minute. This can vary based on the body's condition. Really healthy people may have slower heart rates. Their heart's just a little bit healthier. If they've got a little bit of anxiety, their heart rate might be a little bit faster than 100. There's also some conditions that will make the heart rate too fast or too slow. So it's important to get a patient background history to determine if this pulse range might be normal for them or not. If it's over 100 beats per minute, it's called tachycardia. Tachy meaning fast, cardia meaning heart. If it's below 60 beats per minute, then it's considered bradycardia, which is slow heart. If it gets above 100 beats, 120 beats, or below 50 beats per minute, it's generally considered a little bit more serious in finding. Even if they're physically fit, it will stay above 50 beats in the 50 to 60 range. And most generally, if people's heart is beating a little bit faster, it doesn't go above 120. But during an emergency, it's not too unusual for a pulse rate to be temporarily between 100 and 140. It shows signs of the body trying to compensate. So, what normal situations might account for heart rate outside the normal range? Think about your answer. Maybe if somebody got scared of something, or somebody has maybe been running in a race, or if somebody is physically fit. Like I said before, they'd have a really slower rate between 50 and 60. Some other situations would be if they take a medication that controls their heart rate. Some people that are prone to faster heart rates or abnormal rhythms might be on a heart medicine that actually controls their heart rate. In this case, if you have somebody that's been in a car accident and might be a little bit shocky, their heart can't speed up to compensate for it because the medicine in their body controls that heart rate. In this case, it might be a somewhat more serious finding because the heart's not compensating when it should be. There's two factors that determine pulse quality: the rhythm, and that reflects how regular it is. The heart will usually be at regular rhythms and stay constant, but once in a while irregular rhythms will develop and cause the heart maybe to, what people would say, skip a beat, or maybe even call it palpitations. The second thing you check on quality is force. This is the pressure of the pulse wave as it expands the artery. In a good healthy heart, the pulse is very strong, but once in a while you get a rhythm that's pretty fast or irregular, or maybe there's not much pressure in the vessels, and this would be a thready or weak and thin pulse. Some different locations to look at to check for pulses, and most common one being in the wrist, which is called the radial pulse, and it's on the thumb side of the wrist where it goes across the bone there. And you can put your first 3 fingers on the thumb side of the patient's wrist just above that crease and feel a pulse there. So, as you're checking a pulse, it's a good time also to assess your respiration's rate and quality, because they don't realize that you're doing it. Sometimes if people know that you're checking their respiration rate and quality, then their respirations will change. Not on purpose, but just because they know they're being watched. Another common pulse location is the brachial pulse. This is used for pediatric patients up to 1 year old, and it's in the upper arm, in between the elbow and the shoulder, on the inside of the arm. This is how you would palpate a pulse or check for a pulse. Palpating is to touch on an infant. You can also find some common pulse rates for the various ages on page 310 in your books. So some common pulse locations would be the carotid pulse, which is felt along the large carotid artery on either side of the neck, and this is the pulse that you would check in a patient that is unconscious. Count the pulsations for 30 seconds and then multiply by 2, but if there's a problem with the rate, rhythm, or the force is not normal, continue to count for the full 40 seconds and get a better idea of the rhythm and the force of the pulse. Respiration. When you check respirations and turn to page 312, and there's a little chart there, 13.2, that talks about respirations and normal respiration rates. But respiration is the act of breathing in and out. It's a natural process. A lot of times it doesn't draw our attention. So if somebody's breathing draws our attention, there's probably a problem with it. We also look at rate and quality of respirations. The respiratory rate is the number of breaths the patient takes in 1 minute. The rate of respiration is either normal, rapid, or slow. So you can also call that normal, tachy, or Brady. The normal rate for an adult at rest is between 12 and 20 breaths per minute, but that also depends on their age, whether they're male or female, their size, and their physical conditioning, and also their emotional state. That all influences the breathing rates. Usually rates above 24 breaths per minute are fast, or below 8 breaths per minute are slow, and that can be potentially serious. 4 categories of rates, qualities, of respiratory qualities: normal, shallow, labored, and noisy. Shallow is just where their chest isn't rising full, and they're not getting probably a lot of the air down into their alveoli. So if it's shallow and rapid, they really may not be getting adequate breathing. If it's labored and they really have to work to breathe, you'll see the muscles in their neck and the muscles between their rib cages working really hard, and the diaphragm will also be working to try to breathe air in and out. This is the body working really hard, and that the body will tire soon and will quit breathing. Noisy breathing is not a good sign. That means there's some problems going on, maybe an obstruction in the airway if it's gurgling or snoring, or maybe even the airway swelling, depending on which sound you're hearing. So count the respirations after you assess for a pulse rate. Count the number of breaths taken over 30 seconds and then multiply it by 2 to give you a number of respirations over a minute. But as you're checking respirations, also look at the rate, quality, and rhythm of the respiration. The skin is the color, temperature, and condition of the skin, and that can give us a lot of valuable information about how well their heart is working and their blood is circulating. The color of the skin, and the best way to assess the skin color is in the nail beds and also inside of the cheek or the lower eyelids. Abnormal skin colors will include pale or cyanotic, which is blue-gray, and that's an indication that they're not getting oxygen to all the cells. Flushed or red could be a sign of fever or maybe even carbon monoxide poisoning. Jaundiced or yellow, which is an indication of some type of liver dysfunction. The temperature of the skin is how the patient's skin feels, and you would assess this with the back of your hand, and you'll have gloves on, but you kind of pull your glove back a little bit and feel with the back of your hand on their skin, and you want to know if it feels warm, which is generally normal, hot, cool, or cold. It's how well the skin is perfusing. And here's a picture of somebody checking skin temperature with the back of their hand. For for kids under 6, you would also evaluate the capillary refill. Capillary refill is when you press your fingernail down until it turns white, and then you let up and it turns pink again. You need to count how long it takes for that pink color to return. If it's normal, it'll happen within less than 2 seconds. pupils get checked. That's the black center of the eye. And in a dim environment, the pupils will dilate. If it's really bright light out, then the pupil is going to constrict. If you're trying to check pupils and it's already bright out, the pupil's already constricted, so you're not going to get a reaction. So you've got to actually kind of dim the environment for them to get the pupil to dilate a little if you're going to shine a light in and see if it constricts. So when you look at pupils, look at their size. Cover one eye and shine a light into the other eye and repeat it with the other eye. Both pupils will generally constrict together or react together. So here's how you examine the pupils. So also look for the size of the pupil. Usually it's 1, 2, 3, 4, 5, 6 millimeter in size, and there's a chart on most of our pen lights. You'll see a little sizing chart to match the size of the eye with the size of the pupil. But the other thing you look for is, are both pupils equal, and are both of them reacting to the light. This is a picture of constricted pupils with the pupil in the center really constricted. And then the second picture is of them dilated. And the third is unequal pupils. And this guy, if you were to look at him, could be under the influence of a topical drug. Maybe the eye doctor put an eye drop in it of some sort and it dilated the eye. But these are unequal pupils. Could also be a sign of a head injury or an eye injury. There's a small percentage of population which has unequal pupils that's called anisocoria, but it's an abnormal finding until proven otherwise. That means you have to ask questions and get a pretty good history to figure that out. The blood pressure. The blood pressure is the force of blood against the walls of the blood vessels. The more the blood vessels constrict, the more force that the heart has to push against. If there's a lot of plaque buildup in the vessels, the higher the blood pressure can be. So a normal blood pressure, the systolic is not usually more than 120 millimeters of mercury. And the diastolic pressure, which is the lower number, is not usually greater than 90. But changes in that can indicate something very significant. Blood pressure changes from one person to the next, so that's why we get a baseline set of vitals and we trend, because we're looking for changes in the blood pressure. Not everybody has a 120/80 blood pressure. The blood pressure is measured with a sphygmomanometer and a stethoscope. You would put the cuff over, the blood pressure cuff over 2/3 of the upper arm from the elbow to the shoulder. Just like this picture, you would see where you can, at the crease of the elbow, which is called the antecubital fossa, you would be able to actually find the brachial artery there and make sure that the bladder is placed
Well, before you see the doctor, I just need to perform a couple of tests. First, we're going to step in here so I can weigh you.
Can I take off my shoes?
Absolutely. I always do. And remember, your chart is not a public document.
And I'm thankful for that. But I don't want to know either, so don't tell me, okay?
No problem. Okay, let's go back into the exam room now. I need to take your blood pressure and do a couple more things before you see the doctor.
Okay.
I'm going to take your temperature. Do you smoke?
No, why?
Well, smoking can affect your temperature. So can drinking fluids, but only if we were using an old-fashioned glass thermometer. But you're fine. Open up.
Wow, that's fast.
Technology, isn't it great? Looks like you do have a slight fever. Well, up next, I'm going to take your blood pressure. So would you mind rolling up your sleeve?
No, but take a little of the mystery out of this for me, because the doctor has told my husband to take his blood pressure every day. What is it that you're measuring, and how do you find it?
Well, right now, I'm looking for your artery to be able to hear your heart beating. This screw allows some air to escape from the valve. As the cuff deflates, I'll be listening to hear the first sound of your heart beating and note the pressure at which this occurs. That'll be your systolic pressure. Then I'll wait till I hear no sound at all. That's your diastolic pressure.
So what's the story on my blood pressure, up or down?
Well, your systolic pressure is up to 160, while the diastolic is the same at 82.
So what does that mean?
Well, your systolic measures the pressure when your heart pumps. The diastolic is the opposite, the pressure between beats.
Okay, so when you're listening to my heart, it's the first sound and then basically no sound that matters?
Basically, that's right.
What if you don't get a good reading?
Well, I'll check it again in a minute or two, which probably is what the doctor's going to tell me to do with you. Your blood pressure has never been high like that.
Yeah, I've been under a lot of pressure lately, both at home and work.
2 more easy tests to go. I'm just going to check your pulse and respiration rates, and then we'll have you meet the doctor.
Okay, what do I have to do?
Well, I'll check your pulse first, and that'll take just a minute. So just sit comfortably, and we'll be all set.
Following your initial patient assessment and control of any immediate life threats, you should obtain a baseline set of vital signs, which include pulse, respirations, skin color, temperature and condition, pupil size and reactivity, and blood pressure. The baseline set of vitals gives you a beginning place from which to make treatment decisions. As you retake vital signs, you will compare the readings to your previous findings. This is called serial vital signs. Serial vital sign assessment allows you to note trends in the patient's condition, such as a declining blood pressure or increasing respiratory rate. When measuring blood pressure, you will use a blood pressure cuff and a gauge called a sphygmomanometer. You can collect readings by auscultating or listening to the characteristic clicking or thumping sounds with a stethoscope. Or, when the environment is too loud or the corticoff sounds too soft, you can palpate the blood pressure, which means to feel the radial or brachial pulse with your fingertips while using the BP cuff. To report blood pressure readings, use a blood pressure fraction. The top or first number reported is the systolic blood pressure. This is the pressure created when the heart contracts and forces blood into the arteries. The bottom or second number is the diastolic blood pressure. It measures the pressure remaining in the arteries when the left ventricle releases and refills, or the residual pressure in the system. A normal blood pressure for the average adult is around 120/80. Hypertension is defined as consistent readings with a systolic blood pressure over 140. Low blood pressure, or hypotension, is usually considered a systolic blood pressure below 90 millimeters of mercury. Begin the blood pressure measurement by removing or rolling clothing to expose the bare skin of the arm. Be sure that the sleeves, when rolled, do not occlude the arteries of the arm, preventing blood flow. If the shirt is that tight, remove the arm from the sleeve. Select the appropriate size BP cuff. The cuff should measure 2/3 of the length of the upper arm, from elbow to shoulder. Additionally, it should be long enough to fasten the Velcro securely when the cuff is placed circumferentially around the arm. Place the cuff on the bare arm, following the illustration on the cuff for placement over the artery. With your fingertips, locate the brachial pulse on the medial upper arm near the antecubital fossa or crease of the elbow. Place the diaphragm or bell of the stethoscope over this pulse point. With the bulb valve closed, inflate the cuff until the pulse is no longer heard or felt. Using the stethoscope, listen for the sound of the pulse returning as the pressure in the cuff is slowly released. Note the number on the cuff's gauge as soon as you hear the first pulse beat. This is the systolic pressure, the top number of the BP fraction. Continue to deflate the cuff, this time listening for the point at which the beats fade. Again, note the number indicated on the gauge. This is the diastolic blood pressure, the BP fraction's bottom number. Since you now have both your diastolic and systolic measurements, let the cuff deflate rapidly. Record the measurements and the time. Blood pressure is recorded in even numbers. As already mentioned, you may find yourself in a situation where it is impossible to hear an auscultated blood pressure due to external noises on scene or in the back of a moving ambulance. In such cases, an estimated systolic blood pressure can be obtained by palpation. Since the palpated blood pressures are usually lower than actual blood pressures, an auscultated blood pressure should be taken as soon as possible. The steps for palpating blood pressure are basically the same as used for auscultation. The obvious difference is that you do not rely on a stethoscope to hear the presence or absence of Korsakoff sounds. Begin by palpating for the radial pulse. Inflate the cuff until the radial pulse disappears. Then slowly release air from the cuff until the pulse reappears. At that point, check the gauge for the systolic blood pressure. Report your findings as the systolic blood pressure over P for palpation, as well as the time of the reading.
And this is the chapter review. You can get a great deal of information about a patient's condition just by doing a complete set of baseline vital signs, do a pulse check, respirations, skin, pupils, and blood pressure. The EMT needs to be familiar with normal ranges for pulse, respirations, and blood pressures for adults and kids, so refer to those in your chapter. Trends in patients' conditions will become apparent only when vital signs are repeated. That's an important step in continuing your assessment. So how often do you repeat vital signs? For stable patients, it's at least every 15 minutes. And for unstable patients, you want to do a set of vitals about every 5 minutes. So if there's time to obtain vital signs, or if you must wait to obtain them en route to the hospital, all depends on the patient's condition. Do they have a life-threatening condition going on? And you determine that with your primary assessment. So think about when it's important, when you need that information. When do you apply a pulse oximeter? Should you apply it to a patient having difficulty breathing or one that's not? Consider whether abnormal vital signs are a result of an illness or an injury, or maybe even some other factor coming into play. Alright, so review here. What are the vital signs? What are they? Can you name them? pulse, blood pressure, pupils, respiratory rate. And why do vital signs need to be taken more than once? To trend. It tells us how the patient is doing and whether anything is changing. How much time should the EMT spend looking for a pulse when the radial pulse is absent or extremely weak? Should have that all done within no more than 10 seconds. How should you react when the blood pressure monitor gives a reading that is extremely different from previous readings? You might have to take it again and make sure that it's accurate. And how can you get an accurate pulse oximeter reading on a patient with thick artificial nails? Well, you can put the pulse oximeter, a sticky probe, on different areas of the body and still get it, like the earlobe or the toe or the forehead even on some patients. Sometimes a patient's heart will have an electrical problem and beat more than 200 times a minute. Why is the pulse weak in these patients? Because the heart is beating too fast to get a good blood pressure, or for the heart to fill enough to get a good pulse generated.